Uh, Welcome all. Thank you for joining this webinar, the third webinar of a series organized by the Attica MHPSS Technical Working Group. Today with us we have Dr. Nancy Barron, who I met her, I think, 6 years ago.
Yes, yes.
Yeah, during the IOM and Santana and the University of Essex summer course on migration emergencies and so on. And since then, she has visited Athens and she has worked to help organizations to join her way to support refugees. And she is going to speak about this today with us. Nancy received her doctorate in education at the University of Massachusetts with a concentration in family therapy and counseling psychology. And in 2009, she founded, and since then, she's the director of the Psychosocial Services and Training Institute in Cairo. And that is a partner by Terre des Hommes. And what happens there is that the refugees offer 7 days community-based psychosocial and mental health support to other refugees in an urban context. And this is what Nancy is going to share with us today. She has a very, very long experience in different parts of the world and with different projects, all of them being connected with the support of refugees coming from different countries. And everything will be said in English. So this is all. We can start. Yes?
Sounds fine. Okay.
Sounds fine.
All right. Is everybody able to hear me okay? I hope. Is that okay? Do I sound clear to you?
Yeah, everything goes okay. Yeah.
All right, fine. I'm hearing that other people seem to be talking, so maybe we could mute everybody else. That seems to be better. Okay. All right. So good afternoon, everyone. I am delighted to be able to be speaking to you today. As was said at the beginning, I much would rather be in Athens talking to you in person, and maybe next time. We hope that COVID will go away completely and that we'll be able to move forward with in-person meetings. I am in Egypt. It's only just around the corner. I've had the good fortune to meet numbers of you over the years. Prior to COVID, I did come to Athens, and a few of you have joined us here in Egypt to come and see our program here. And using what you learned from here, we're able to start some lovely programs of your own. Today, I was asked to speak about refugees assisting refugees, and specifically about community-based mental health and psychosocial care in the urban context. It's always hard with an audience that you don't know to figure out where to begin. I don't know what you already know, and I don't know what's repetition to you. So what I'm going to do today is I'm going to try to do some basics, at the same time connect that to the work that we do here in Egypt. So I hope that we can have some dialogue, it's always hard online to have dialogue, but I will ask some questions, and I'm going to hope that some of you will feel comfortable to talk. From what I know is that some of you have quite a bit of experience in MHPSS work already, and have already been working both with refugees and in community-based care. So I hope that this will be a useful addition to what you already know. So the special factors in today's workshop will be that we're doing an examination of community-based MHPSS interventions for refugees specific to the urban context. And it specifically will look at a model for refugees assisting refugees. The next slide, please. Our learning objectives today. Yeah, the next slide. There we go. The learning objectives today, first we'll do a review of like urban refugee care. What does that mean? I'll then look with you at community-based mental health and psychosocial interventions specific to, we'll look at the urban area. And then I'll present to you the model that we use here in Egypt. The next slide, please. So maybe if I could engage you from the beginning, let's hear if I could hear a few of you. Maybe if you could just say why you're interested in a class on community-based mental health care, mental health and psychosocial care. It's specific to the urban context. And maybe a few of you could just share with me what you think would be your expectations for today. Why are you here? What are you hoping to get from today? Yeah, anybody to share? I think it's easiest if you just speak out, because I can't see your hands and I'm not controlling it. So it would be great if people could just speak out. So why are you here? What are you hoping to get from today?
Hi, this is Paro from India.
Hi.
Hi, Nancy. Nice to meet you. I'm hearing about your work for the first time because I recently graduated from LSHTM with a master's in public health. But I've been working in the mental health space for the last 3 years, particularly working on community-based interventions in an urban setting in India with economically disadvantaged populations with severe mental illnesses. And I also have a growing interest in looking at community interventions to help rural populations in India, which have a lot of immigrant laborers and families who are affected by the COVID pandemic, especially in the country.
Okay, thank you. And where are you in India?
I live in Bombay.
In Bombay. Okay. All right, wonderful. I've been to Bombay. What a city.
Yeah,
what a treat.
Yeah, same here. Thank you.
Thank you. All right, thanks. Who else? Why are you here? Yeah, anybody? Oh, I know if I was standing in front of you, you'd all be answering. Please, go ahead.
Hello, I'm Kotimi from Greece, from IRC. So for me, one of the interesting differentiations about the urban area, rather than the camps, because we are now working in urban area in Athens. So in the camps, I think the context is a little bit different according to the community based on my experience. So I'm really interested to hear about your experience in it, about the urban area, how it work. We're already doing, try to do, but due to the difference of the context, I'm really interested to hear about the experience of it.
Great. Okay, thank you. What is your name?
Me.
Yeah, what's your name?
My name is me from IRC.
Ah, nice. Pleasure. Okay, good. All right. Anyone else? Anyone else? No? All right, so then I'm going to assume that the two of you are somewhat representative of everyone. That would mean that some of you have some experience already working in the urban area with refugees or with displaced people, as well as others of you that would have experienced working in camps, and that recognizing that, you know, the urban area is different than camps. And today we're going to look at how is it different, and then what do we do that is different. The next slide, please. So let's just start with the idea of the urban context and worldwide urbanization. You know, the world has been undergoing an ongoing process of rapid urbanization. It's not just refugees, but in 1950, there were less than 30% of the world's population living in urban areas, and now it's over 50%. And by 2030, they expect it to reach 60%. In 1950, there were 730 million people living in urban areas. That's quadrupled in the past 60 years, and there's now over 3.5 billion people. So the idea of urbanization and people moving into the urban context is a global issue. It's not just a refugee issue. The next slide, please. The next slide. There we go. So displaced people in the urban context. Well, you know, the statistics on urban refugees and IDP are not completely reliable. However, UNHCR now estimates UNHCR estimates that 60% of all refugees actually live in urban areas. I know that when we first started working in MHPSS work for me, you know, now more than 30 years ago, it was nowhere near that. So this is up approximately 15% from 2003. The 2018 World Refugee Council talks about 60% of all refugees and 80% of IDP living in urban areas. They're saying that's about 17.5 million people that don't live in camps, but live in urban areas. So, you know, this kind of discussion about urban care really is very important. It's more and more obvious that we need to learn how to work in the urban context if we're going to help displaced people. And it's no longer enough to be thinking about camps. The next slide, please. In 2009, UNHCR shared its first policy on refugee protection and solutions in the urban areas. And this was really important because it marked kind of this new approach for them with refugees. It was the first shift for UNHCR away from giving all of their attention to camps. This was making kind of rather clear the idea that the refugee issue for people was not a short-term problem, and that people were living as refugees longer and longer. I know that here in Egypt, we have people, you know, as refugees for 25 years. In other countries, it's far longer even than that. All right, so that they began to have to recognize that, in fact, this is not a short-term issue, and that urban care could potentially be a more permanent solution. The UNHCR policy ensured that cities were recognized as legitimate places for refugees to live in and to exercise their rights. And then in 2014, they actually updated that. And they actually started to advocate saying that camps should be the exception, and that wherever possible, they should be phased out, and that in fact, people should be in the urban area. The next slide, please. So I wonder then, you know, if we think about the urban area, what are our challenges? I mean, why is this such a challenge to work in the urban areas? Do you have an idea? Anybody have some ideas? Why is it a challenge?
Because they probably don't know what healthcare they can access, or if they're eligible to access certain forms of healthcare and they're not covered by it, or just not aware.
Yeah,
or
so
not
the first
afforded.
problem, yeah, good. The first challenge is access and information. Is that in fact, in the urban context, it's a lot more difficult to get information to people. And then in fact, what happens is that, you know, a person arrives into an urban center. There's no signboard that says refugees come here, or here's where you can get your services. So the first is the challenge of good information and access. Yeah, what other challenges do we have? Other challenges?
If I may.
Sure.
In many countries, urban contexts are chaotic, and it's very difficult to navigate in such contexts, and people feel shocked many times.
Yes. So, you know, imagine that you come to Athens, and of course you don't speak Greek. I mean, you know, and the city is chaotic. Imagine Cairo. Anybody who's ever been here, the city's crazy. You can't even cross a street. So that the cities themselves are chaotic, confusing, and even more difficult if you don't speak the language. Yeah. Other ideas? What are the challenges?
If I may add something else, maybe
Sure.
they are also exposed to possible risks.
Sure. Yeah.
But also aggressive behavior from the host community.
Yes. Okay. So there's greater dangers than we seem. It's not that camps don't have dangers; they have dangers of their own. But the urban context has a whole range of dangers and possible exploitation. Yeah. So first of all, then let's look at the next slide, please. The next slide. Yeah. You know, there are some benefits. All right. So cities allow refugees to live autonomously. They can hopefully make money and build a better future. And in the end, we hope that life is more normal, especially if it's long-term life. But the challenges, the next slide, please. Challenges, I think, are huge. First, that we actually have not had a model for MHPSS care and in the urban context. And in fact, most of our models are for camps. And truly, you can't just transfer a camp model to the city. Certainly, as was said, that there are lots of dangers and protection issues. Refugees are very vulnerable to exploitation, to arrest, to detention. They become competition for the poorest host country workers, for the worst jobs often, and often at the lowest end of life, that they come into a country very poor and even more complicated if they don't speak the language, because it's not easy to fit in. Challenges, basic needs, housing, food, healthcare, education. It's a tremendous challenge right from the beginning, not only to know how to access, where to access, but even if they know where, how are they supposed to pay for it? How are they supposed to actually get those services? I think sometimes it's the hardest when they are coming into a situation where it's first world, and it's first world, second world, third world, and there's a lot there, and everybody wants what's there, and yet they don't have the money or the resources or the know-how how to access it. A challenge is relationship with the host communities, with their neighbors, with the communities. The complications of, am I integrating? Am I affiliating with my new neighbors? Am I associating them? What is it that I'm trying to do as a refugee? How do I live alongside of people in harmony? And then we have the social problems of the communities. The communities themselves already have a lot of problems. They might have problems with substance abuse. They might have problems with discrimination of their own people. They might have economic problems. And of course, refugees come in and the displaced come in, and they are seen as part of the social problem. But whatever problem there is for the people of the country, of course, those are the problems for the refugees as well. There's huge issues of competition, where the local communities are feeling that refugees come in and they're taking their jobs, they're taking their homes, they're changing their lives in some way. And so there's competitions and there's fears. And then there's the big challenge of refugees coming into an urban context and even finding them, identifying them. In a place like Cairo, we'll look at, I mean, how do you even find the most vulnerable? In Cairo, we have 20 million people and 280,000 refugees. How do you even find them, right? And then this whole idea of self-reliance. I think we all hear about this all the time. The goal for refugees over and over is they're supposed to become self-reliant. They're supposed to learn how to take care of themselves. And if they're supposed to learn how to take care of themselves, then how exactly are they supposed to do that in an urban situation where they don't have the proper resources, they don't have the money, they don't have the language, they don't have the skills, and they're not necessarily well accepted? So how in the world are they supposed to access this whole idea of self-reliance? So I think that there are tremendous challenges in the urban context, tremendous challenges. And yet, if we look at it over the long term, if you're a refugee and you might be in a country for a very long time, 5 years, 10 years, you might be having your children's children in that same country, then do you really want life in a camp? I would suggest no, that you would much prefer to be in an urban context. So that the sooner people are moved over, or in fact start in an urban context, the greater opportunities they actually do have for the rest of their lives, that they will be a displaced person. Are there any questions about that? Anybody with a question?
You mean about the problems, needs, or common for emergency?
No, about what I've just been talking about the challenges.
I have one question.
Sure.
I understand all the challenges, but from my mind, it's about how to identify the more vulnerable and how inside the camp the communities are more organized.
Yes.
So the sense of belonging of someone and the identity, the sense of, we're talking about integration in an urban setting as a refugee.
Yes.
Is it a challenge about how to be connected with his own community as well? Because urban area maybe make it more difficult, especially if it is not organized.
Yes.
For
Yeah, I
example,
think that's,
countries
yes.
in Middle East, for example, in Lebanon, there are camps in the middle of Palestinians that they try to organize their own communities, but
Yes.
mainly in Greece, I cannot see that.
Okay.
I don't know if it's a challenge.
Yes, I think it's a tremendous challenge, and that I'll talk when I move over to start to talk about here, is that how do we identify the most vulnerable? And then how, I think that every human being wants to feel a sense of belonging somewhere. I think that's part of human nature. And I think that for refugees, they're often struggling with that. And in the urban context, you're very right that if there are communities that they can find, like here in Egypt, and they can find a community of Somalis, they can find a community of Eritreans, and they find their own people, that makes it a lot easier. And that I think that it's also the tremendous challenge in the urban context if that's not there, or if in fact they can't find it. Because that means that they're left with no easy place to feel like they belong. So it's very much a challenge of the urban context, is to find a way to really feel that you belong somewhere and that you're attached to somebody. So a very important point. So let's move to the next slide. That's the slide you have now. The problems and needs that are common for emergency affected populations. I want to talk a little bit about what problems are common. And I talk about that first before I talk about intervention, because I very much am a believer that interventions must directly relate to the problems. So before I can kind of talk about interventions, we need to be thinking about what are the actual problems. All right, so the next slide, please. The next slide, please. So the Interagency Standing Committee guidelines on mental health and psychosocial support give us some kind of ideas about the research from a long time ago now, and now also from today's times, about what are the actual psychological and social impacts of emergencies. And that what we know is that in fact that most people don't develop serious mental health problems. Most people, have periods and times of emotional distress, and that this emotional distress very much is important and threatens their daily life, but that they're not huge numbers. Excuse me, they're not huge numbers of people that are actually mentally ill, but rather a lot of people that have high levels of emotional distress. The next slide. Excuse me. I'm sitting in an air-conditioned room that's too cold. One sec, let me just turn it off. Okay, so next slide, please. Oh, you've got it already. So what are the consequences for emergency affected populations? So there are immediate consequences. The immediate consequences, as well as there are consequences over time. There are consequences for individuals, families, communities, societies. Every emergency is different, and it very much differs according to the context, the culture, and the available resources. Often, most often, the marginalized and discriminated groups who were discriminated back in their own home countries have the hardest time. Most of the time, the consequences after an emergency, for an emergency affected population are negative, not always. I mean, sometimes you might find in Greece that in fact, people who had a lifestyle back in Syria that had less opportunity might even feel that they have more opportunity in Greece. So that it's not always negative, though much of it is negative. The next slide, please. I find that the mental health and psychosocial consequences for any emergency affected population, be it the short term or the long term, are created through a combination of past, present, and future. So it's a combination of what happened to me in the past connected to what are the problems, the needs, and the resources available to me now, connected to, very importantly, my future opportunities. So that it's not only about what was my problem from the past. I think that we'll learn that, in fact, that's actually less of the issue. And what's most problematic for people is present and future. The next slide, please. So, and immediately after an emergency, there's huge amounts of stress of how to feed and protect one's family, whether that's in Afghanistan or that was in Greece, whether that was, and originally for many people, all right, that was what directed everything about what they were looking for. The interventions they needed were about their basic needs. They needed to understand how to feed and to protect themselves. The next slide, please. That what we realize is that, in an emergency or after an emergency, that people are amazingly resilient. That they can go through the worst of times, but that they most often can find some kind of inner strength in order to manage it and to cope. To cope does not mean that they don't suffer. Of course they're suffering, and of course things are hard, yet they're able to cope. And that means that they're able to move on with their lives, and they're able to find ways to find a new way to manage their lives for the present. The next slide, please. We know that during and after emergencies, that immediately afterwards, people have high levels of emotional distress. We expect that. All right. And so that the interventions that one would need immediately after an emergency in order to help to manage the emotional distress are very different than the interventions in some ways that we need later on. The next slide, please. Early on, people have lots of symptoms of distress, feelings of despair and anger and fear and grief. There's changes in eating and sleeping, psychosomatic aches and pains, difficulty concentrating, hard times with social relationships. We know that at the beginning of an emergency, all right? We expect that at the beginning of an emergency. Over time, that changes, all right? Over time, and those things are not mental illness. They are the normal symptoms of distress. So again, interventions would be different in response to that than they'll be later. The next slide, please. We know that after any emergency, people are trying to maintain a sense of well-being. That it's easier for them to do that if they had a sense of well-being before the emergency. And that what we realize is those people who were in trouble before the emergency, emotionally, mentally, socially, are in more trouble after the emergency as well. What we also know is that life becomes kind of this chain of stressful experiences. That this chain of stressful experiences with high levels of feelings of helplessness that can even interfere with the normal development of a person. The next slide, please. Again, people have protective factors. And as your colleague said a little while ago, the protective factors that have to do with having a social support system are critical. People who have social support systems do better than people who don't, all right? That's part of what helps them to make them resilient. That's part of what helps them to cope, all right? So that in fact, it's a very important part of intervention is to recognize that people need social supports. And as we look at the urban context, we'll begin to look at how important social supports are actually to people. The next slide, please. I think that what we find is that, many people talk about people have suffered terrible traumatic events and that we have to manage that. I don't see that for the most part. What I see is that people, when they are emergency affected, over the years of being emergency affected, the problems that you have to help them to manage are the hassles of daily life. Over time, the survivors of emergencies complain absolutely the most about the hassles of daily life. They complain about, where am I going to eat? Where am I going to, how am I going to live safely? Where is my healthcare? And the hassles that go along with trying to get the services that they need. The next slide, please. Also, that I think that, for any displaced person, whether they end up in Athens or they end up in Cairo or they end up in Lebanon, is that, before they were displaced, they had a style of life. They had a certain way that they lived. They had a certain routine certain daily activities, a life purpose. They had traditions, customs, right? They had a certain way that was acceptable for them to behave themselves and alongside those that they cared about. And what happens with an emergency is that change of a way of life, that suddenly you can't have the same cup of tea. You can't have the same life purpose anymore because what you would hope for before is no longer possible today. And the sad thing is that most of those changes are permanent changes, lasting changes. Frankly, most often for someone who's been displaced, life will rarely be the same again, right? And that change to a way of life is what causes huge amounts of emotional distress. And that is part of what we need to be addressing when we're dealing with interventions. The next slide, please. I also find that, in fact, that sometimes humanitarian aid is part of the problem, that the feelings of distress can often be because of the way in which aid is provided. People quickly become very dependent on aid, be it that in a camp or in the city, all right, that they are wondering, where do I get the care? Who's going to help to pay my rent? Who's going to help to put my kids in school? Who's going to do this? Who's going to do that? And unfortunately, very early on, especially in the urban area, is that people are disappointed, that they're trying to be dependent on systems that are not dependable, right? That they find themselves without proper information, they don't have adequate basic needs, that oftentimes the care that's provided is inequitable. And then there's conflict and competition for resources. And this feeling of not getting what they need from humanitarian aid often leads to feelings of anger, frustration, helplessness, and that sometimes our humanitarian aid in its best efforts are also damaging culture and norms and traditions by pushing people into trying to fit into where they are, is that sometimes we can also do damage to who they were before. So I think that also part of our problems is sometimes our own approach to humanitarian aid, be it in MHPSS, be it in healthcare, be it in food distribution, or in the way in which we do basic needs. I think that unfortunately sometimes the problems that people are struggling with, the hassles of daily life, are what are causing them problems, and sometimes the humanitarian aid or what they thought it should be is part of the problem. Do you have any questions? Questions about what I'm talking about? Because we're now going to talk about how do those problems lead into interventions. Any questions?
Not question, but a comment.
Sure.
That it is crucial to underline all this that you say about the humanitarian aid-induced problems, or the fact that people do not develop some kind of mental health problem or even less mental disorder after being exposed to a series of adversities. You need to underline this because many times we easily pathologize behaviors of people and people themselves. And it is the easy way to find solutions to the challenges that we meet when we work with these people, to say that it's their fault because they are not well, they are mentally ill after they have been exposed to wars and persecutions and all these adversities. And yeah, I think you need to underline this and to highlight.
Yes, I agree with you. I think that we'll continue to look at that in intervention, because I mean, the reality is that the reason I talk about the kinds of problems I talk about, hassles of daily life, changes in culture and tradition, and the problems of humanitarian aid, is because in truth that our interventions need to address that. Because that's where the biggest problems are, is that yes, we need interventions for mental illness, from people with mental health problems. Yes, that's true, but that's a small part of the problem, is that we find that in fact, people have many other kinds of problems causing them emotional distress, and that emotional distress needs to be addressed through our interventions. And there's just different ways of doing that than some of the standard ways. Yeah. So I very much agree with you. Yeah. Other comments?
I agree
Questions?
totally with you. And just to add a bit what Nikos mentioned is that in Greece it was very common to create vulnerabilities in order these people have access to common services.
Yes, I mean, you know, that if people could access the services that the host country could access, all right, by living in an urban area, I guess that would, for some, would take care of the issue, all right? But unfortunately, most of the time they can't, all right? And that they're either not welcome in that, or for whatever other reasons, they're not able to access it. Some, as your colleague said at the beginning, because they don't even know where the service are. And then others, of course, because of language and accessibility and many other things. Yeah, but it would certainly be easier if they could access the services that are available to the local population. Yeah, other comments?
I just have a quick comment. This is Parvati. I don't know if I've missed this, but at least in India, and especially in the rural population, or even people who are from the rural areas working in the urban part of the country, I guess they're not able to even acknowledge at times what they're going through and maybe express it. Like they're not able to articulate what it is that they're going through, because there's also a lot of stigma and also a lack of awareness. So they just can't express. So if they can't express or understand or acknowledge to themselves what they're going through, how will they know where to go to?
Well, but you know that, yes, if, you know, I mean, certainly that, but what is it that we need them to articulate? I think that, yes, people do not come to, they don't announce, you know, I'm emotionally distressed and therefore I can't sleep at night. But they do go to a health center and say, I can't sleep at night, or my back aches, or I have headaches. So that I think it's that also we also have to be able to hear them for what they can say. And I think that people in many different cultures articulate in different ways, but they're still telling us what their problems are. So I think we have to be aware of each culture and what they are saying to us, and then meet them where they're able to articulate. I think that over time, you know, I've found different countries that I've worked in, eventually people are able to maybe say when they're very emotionally disturbed that that's the case, but that's not always what people have to say for us to kind of know what we need to do to help. Again, I think that the majority of people, we're not dealing in mental illness. The majority of people are dealing with emotional distress due to life circumstances, and that's what we have to help with. Yeah. And so let's look on to the next slide, please. Is how do we set up interventions then? You know, that what is it that we actually do to set up interventions? So the next slide, please. Well, you know, experience over time leads us to know that, you know, mental health and psychosocial consequences of emergencies, you know, they have certain kinds of problems. We know that, but we still need to be doing assessments for every specific situation so that we understand the needs and the problems and the resources for that population. And it's the gaps that we find that are actually where we're supposed to put our interventions. I teach interventions and about interventions all over the world. And I think that commonly that's the most complicated point. That I think that oftentimes organizations and individuals do interventions based on what they know how to do, based on what their organization's mandate is, based on what they have decided or pre-decided are their ideas and what they have as capacities. I think that what's important in organizing interventions is that what we need to do is be doing assessments so that the things I just described before are the certain baseline of things that we understand, but we know that it's different for every population. So an assessment lets us know where the primary needs and problems are. It allows us to know where the resources are, and then it helps us to be able then to design interventions to meet those, that meet the gaps. The next slide, please. So assessments determine problems and needs, the assessments determine existing resources, and then the analysis of that assessment actually leads to the gaps, and the interventions are what we should be doing addressing the gaps. The next slide, please. So, what's that possible range then of MHPSS interventions? What is possible? All right, so then the next slide, please. Historically, MHPS interventions 30 years ago were quite different than they are today in today's times. 30 years ago, now a little bit more than that, there was very little thought about MHPSS. And that I know that I began in, I moved overseas 32 years ago. And when I first moved overseas, I was an experienced psychologist, clinician. And what was interesting was that well, there was no work for me anywhere. People didn't have a clue about what a psychologist could do, and neither, frankly, did I. And over the last 30 years, I've had the good fortune of being engaged in this and learning over time and experience where I could and could not be helpful. And I think that slowly over time, over the last 30 years, people have begun to include MHPSS in assessments. I find fascinating that every proposal that you look at now from whatever organization has this piece of MHPSS in it. So times have really changed, and it's very much a part of almost every emergency response. The next slide, please. In 2007, we developed guidelines for mental health and psychosocial interventions. I frankly think that they are still very useful today. Some pieces of it more than others, but I think the overall principles remain just as important. The next slide, please. And then what they do is they help us to take, and figure out what interventions we should use in order to intervene, assist, manage, or treat the issues or problems. The next slide. The guidelines were established because, frankly, in the field in 2007, there were many different crises. First, it was the Kosovo crisis, and then the former Yugoslavia crisis, and then the tsunami. And I think we realized with MHPSS that we were making a lot of mistakes, and that there were the guidelines were needed because we were making mistakes. The next slide, please. Some of you may be already aware of the guidelines, and I'll only review it briefly because the guidelines form the basis of what intervention is, and it will frame what I'm going to talk about for community and what I'll talk about here in Egypt. The guidelines, were developed were not just developed for psychologists and such. They were developed for everybody. And I appreciate that the guidelines have direction for water and sanitation and for education and for healthcare. And what is clear is that it is just as important for a person providing water and sanitation or providing healthcare to know how to provide their service so that it supports psychosocial well-being than it is for us to set up psychosocial intervention. I believe that there are many, many ways in which we help people that come from meeting their basic needs. And I'll talk about that when I talk about Egypt and about the importance that these guidelines place in being able to have a holistic service that is able to respond at all the different levels of care. The next slide, please. The people, have different responses in emergencies for different situations. You can also have, 10 people in one situation with the same problem and all have a different response to that. So again, you can't just transfer what we know from one emergency to the next. What the guidelines do, next slide please, is that they build on the available resources. And that's what I appreciate most, is that they are very community directed. They very much believe that the people who have problems are people who who have assets and capabilities, and that they should be utilized in their own self-care. They believe on building on those local capacities, strengthening what people have, and not just bringing interventions from outside in, but in fact, figuring out what people have done for a lifetime to take care of themselves, and in an emergency, help them to do that. So people like us, the strength of us is that we should be helping emergency affected peoples to really, truly find the ways that they know how to help themselves and to use those skills in places that are in Athens, in Cairo, in somewhere else, to not just dissolve them, but to take advantage of what people do have and utilize them. The next slide, please. They also talk about integrating social supports. You know, the idea that they should be, that, and this is what I mentioned before, is that they should be integrated. So psychosocial care integrated into education, all right? Not just a standalone program. They don't suggest that you ever have these standalone rape centers as an example, but rape crisis response should be inside of healthcare. So nobody's going to come to a rape crisis center that has a great big sign that says, here's my rape crisis center. But people will go to a healthcare facility, right? And more likely that they can articulate their aches and pains in that healthcare facility with a knowledgeable person who is able to understand what they might be saying and then be able to deal with it. The next slide, please. What I like the best about the guidelines is the whole multiple layered support system, recognizing that there's a whole range of problems and thereby you need a whole range of interventions, and that all those interventions need to be done at the same time. The next slide. And what they talk about are 4 layers of intervention. All right, that, you know, the first layer is what we talk about for, you know, people who are struggling with their basic needs, struggling with basic services, struggling with protection, and that in fact interventions at that layer are helping with those things and helping with those things in a dignified way. Right. The next layer is all about family and community support. The next is about helping people who are emotionally disturbed, where it's not enough to have layers 1 and 2, and they need some kind of additional support, not necessarily by a professional worker, but somebody to give them some additional support. And then layer 4 is for the folks that have the most serious mental health problems, who are needing a more specialized staff, more professional staff. Yeah. What's interesting, and I think most important about this pyramid, is that it does what Nikos was saying earlier, which is it makes clear that the top layer is the smallest. And that top layer is the smallest, is telling us it is critical, it's necessary, but it's not where we put all of our energy. And that it's very important to be putting our energy also at layers 1 and 2, not just at layers 3 and 4. And I think over time, people have understood that more. But if you look emergency by emergency and urban area by urban area, I think that you'll find that there's a lot of concentration on layer 4, when in fact there should be very much concentration on these other layers. The next slide, please. I already said that, yeah. Right. So comments about what I've just been talking about before I move into community-based care. Anybody? Comments?
I just have a quick question. I'm not a psychologist or a psychiatrist. I'm a biotechnologist who recently became a public health researcher. In what way can I contribute? I know I cannot contribute to the last layer, but is there any way that I can equip myself and upskill to be part of an intervention apart from just developing it as well?
I think
in
very
consultation
much so.
with mental health professionals. Yeah.
Sure. I mean, I think that I think that for everybody, the first thing is that all of us should understand something like this pyramid so that we're advocating in the right places. I think that there's a lot of the world of MHPSS that is still, unfortunately, only advocating at layer 4. And that again, it's an important series of interventions, but not all. I think that where everyone can be advocating and helping is with the interventions that are the layer 1 interventions in particular that I'll talk about, where in fact that, you know, you're a public healthcare specialist. All right. As a public healthcare specialist, I would suggest that I've seen many a healthcare program that does not support psychosocial well-being. So that you have, you know, I was at a center not long ago where, you know, people are sitting out in the sun, you know, that there's no water, that you've got health attendants that are abrupt and abrasive, and so you just by the very nature of the health facility, up the emotional distress of the people. Right? That people walk inside and people aren't necessarily kind and compassionate or listening, and thereby immediately people are not willing to talk, right? That they're not willing to say, you know, that this is what my problem is or that is what my problem is. So what can you do? What can you do? Well, from the very beginning, I think understand that psychosocial well-being starts with things like healthcare and basic healthcare and things like that. I think that as far as, you know, being able to learn more skills, psychological first aid is used all over the world as a skill set in emergencies, and it can be taught to anybody that works in care. And then in today's times, there are other intervention sets that require more skill at layer 3 and at layer 4. But psychological first aid is something that's learned by everybody. Yeah.
Great. Thank you.
Yeah.
Can I
Other
highlight
comments?
something? Just to mention that after a crisis, usually, as you saw in the IASC pyramid, a small percentage of people need access to specialized services. If you cover the other 3 layers, then at the end, there is only a limited number, because you offer them the basic, the option to develop their own resilience after the event.
Yeah, I think that's absolutely right, Chrysanthi. And that, and I think that, you know, if we're in an urban context, it depends on the context. If it's a country that has mental health care, then the goal would be to help the people who are the refugees and displaced population access the local care. I mean, that would be the most logical, right? So if that's possible, you know, in many urban contexts, I think that, you know, I've been many where in fact that's possible. It may not be perfect. It may not be it may not be perfect care, but it's care, and it's the care that's available in that country. And so that level 4 then could be accessed publicly, and then you have the rest. So, you know, again, I think it's keeping a perspective on where the people need services, and they need it at all the layers, but the less people need it at the top, yeah, and more people need it elsewhere. All right, now, Chrysanthi, should we? I was thinking that we might take a break every hour for like 5 minutes or something, just to keep people engaged. Is that a good idea?
It's a plan, I think. You follow the rules. From the previous training, that's it's
Right,
also Dukas here.
Huh?
It's also Dukas here from the PSTI training.
Hello, Nancy.
Yeah, hi.
Okay, so we're going to have 5 minutes break.
Yeah, sure. Let's just take like a 5 minute. It's what, 2:05 right now. Is 5 minutes enough? Just to go to get some water, go to the bathroom like that for people, just to breathe?
Yes.
Yeah, perhaps, yeah.
Yeah, okay. So let's just do 5 minutes
We do
and then
it
we'll
every
come.
5 minutes, okay.
Yeah, perfect. All right,
Every
perfect.
hour, I mean, not every 5 minutes.
Perfect. All right, no problem. All right, so let's
Okay,
just
thank
take a
you.
brief break, yeah?
Okay. Έχουμε break. Μαρίνα,
Α, οκ.
για 5 λεπτά.
Είχα δει... Μπήκατε στις 2.
Ναι.
Είχα μια συνάντηση. Οκ.
Εντάξει.
Μέχρι τις 5.
Move up. Let's move forward a little bit on those slides. All right, there we are. Okay. So, I hope that we're moving our way, up to different kinds of interventions. So now what I'd like to do is talk a little bit about community-based interventions. So today we had said that, we're looking at community-based interventions in the urban context, refugees assisting refugees. So let's look a little bit at community-based interventions. So the next slide, please. So, good MHPSS interventions utilize this kind of holistic biopsychosocial approach because well-being really depends on this interconnectedness between, physical, social, cognitive, emotional, and spiritual elements. MHPSS interventions are designed to activate and restore natural supports within community and family care systems, something that's essential during emergencies as well as over the long term. It's not just for the emergency, but over the long term, that we should be really promoting natural support systems and not just outside intervention. The next slide, please. And that's why the interagency guidelines, support and encourage people to facilitate community-based interventions. Interventions that engage the participation of the community, it's believed are more likely to be meaningful and sustainable. And what they do is they help restore people's sense of competence, their self of agency. It makes them feel hopeful. If you go in, or I go in, and help them and tell them what to do and direct their lives and control their lives, that certainly doesn't make people rebuild their sense of competence. If from the very beginning of an intervention, I'm engaging communities and in fact with them, helping them to develop what they want or how they will best help themselves, then from the beginning, I'm developing their competence. Just because they've been, the survivor of an emergency doesn't mean they no longer have any capacities. One day they were people who were taking care of themselves, and then the next day they were not. That didn't mean their skills went away. It just meant that the circumstances changed. So I need to be able to figure out how to help them to restore what they had before. Community-based MHPSS approaches work with and through natural support systems. They strengthen those natural support systems. All right, the next slide, please. All affected groups have assets or resources that support mental health and psychosocial well-being. And again, the key principle from the beginning is helping wherever possible to help them to do that. The next slide, please. Again, as I said, it's important that we're not damaging natural supports. So by helping people to help themselves, that in fact, that it's engaging whatever it is that they did before. It's not just talking about them, but it's actually having communities engaged in a partnership so that they're actually owning interventions. The next slide, please. I mean, I believe that there's some very simple styles of community-based intervention. In the early days of community-based intervention, I know that when I first became involved it was the 1960s, that the institutions in America were closing down. And as they closed down the institutions for people with mental illness and for people who had any kind of cognitive problems, all right, they were setting up a community mental health movement. What was interesting was that they would close the hospital, but all they would do is take the mental health clinic out of the hospital and just place it in the community. They actually didn't change much. They just changed the placement of it. So they said that it was community intervention. Well, it was intervention in the community. So the service was in the community. There's another kind of intervention that is for the community. That means that there's a lot of good people who provide interventions, right? And they do it for the people of a community. they're not necessarily people of the community, but they're doing interventions for the communities, right? And then there are interventions that are with the communities, where people go in and they ask them, what do you need? And they do it with them, all right? But then there are models that are of the community. The model I'll talk about today is of the community, which is that the community is designing it, the community is doing it, the community is taking responsibility for it more and more themselves. And so that it's of the community. The people doing the intervention are the people themselves. The design of it is from the people themselves. The monitoring and evaluation of it is of the people. Right. So I think we have these different kinds of community-based interventions. Some people prefer one more over the other. Today, I will talk about the of the community. The next slide, please. So what are some of the challenges then in community-based interventions? Some of you do community-based. All right, so what are some of the challenges? What makes it more challenging than just kind of going in and doing things for people? What's more challenging about engaging the community?
At least in an Indian context, I see that there is hesitance to sort of voice to the local community leaders or even community workers as to what their psychosocial needs are. There is reticence.
Yes.
So there's not much communication. Yeah.
Yeah. Okay. So that they're not sure they should trust you. They're not sure if they want to be engaged. They're not sure what your intention maybe is. Yeah. So there's a reticence. There's a hesitation. Okay. Others? What are other challenges in implementing community-based intervention? Other ideas?
Language barrier.
Hi. Yeah, go ahead.
Language barrier.
Yeah, for sure. You know, is that you have people that might be speaking Tigrinya, they're speaking Somali, they're speaking other things, and the people who are trying to work with them don't speak the local language. So if they don't speak the local language, then they're using translators, community mediators, other people standing in the middle with them. Yeah, so that's a challenge, absolutely. Yeah. I've also seen challenges of community-based interventions where, because the people coming in speak English, that they in fact start to look for, they say, we want to start we want to work with community leadership, but community leadership doesn't speak English. So then they find the people who do speak English. Well, the people who speak English might be, you know, young people who, you know, watch television, all right? And so that they are not the leadership of a community. And yet we sometimes will form a new leadership based on the language that we can communicate in. So it certainly could be a challenge. Yeah, other ideas? Other thoughts?
Personally, I don't know what community is today. I mean, we speak about community, but to me, it is a very abstract term. And I really do not know where to find it, let's say.
Yeah. You know, so that's an interesting comment, Nikos. Yeah. It's interesting that I think that if I'm sitting here in Egypt and I say to a Somali refugee, who is your community? They have no question whatsoever. You know, so they would say to you, well, I live in this neighborhood and this group of people lead this association and they live in this neighborhood and we're from this tribe. This is my community. So it seems that, you know, culture by culture, situation by situation, community is somewhat different. You know, community being those people that, you know, that we have an interconnectedness with, that we have a commonality with, that we share, whether it's activities or traditions or beliefs or supports, but there's something common that connects us together. And what's interesting is that here in Egypt, you know, refugees easily connect to communities, but that's not so easy in many other circumstances. So that I think that's a good point. Yeah. Other comments? Other challenges? I think there are lots of challenges. Next slide, please. I mean, you know, working with communities takes a lot more time and sensitivity. That it is far easier to just go into a situation and start telling people what to do, assuming you know people's needs and problems, assuming that you have enough sense about who people are that you can do it. Community work takes a lot more work. Like Nico said, at first it means finding the community. And then it means listening to people and listening to their ideas and accepting the fact that maybe what you think is a good idea is not what they think is a good idea. And that in fact, what works better for them is different than what works better for you. And that, you know, that it's important that in working with communities that you're able to accept and work with differences in norms and gender and stigma and all these things that are different than your own. Community approaches also can be dangerous, you know, in some situations that in fact that communities connect to political situations, and these political situations might be part of the reason that the people are displaced in the first place. So people from the outside are not particularly aware of that, and people like ourselves can certainly walk right into a mess if we're not conscientious about understanding who communities are. So I think that community work is most definitely challenging. It's most definitely more time consuming. And situation by situation, first it requires figuring out who is the community. Next, it requires helping the communities to identify what their challenges are, what they need, and helping then communities in how they can best help themselves. Sometimes that's very difficult when their expectations are that you're supposed to help them rather than they're supposed to be helping themselves. And I think that's one of the great challenges in community work, is helping people to recognize that in fact, self-reliance is going to be the best way to help themselves. The next slide, please. It's the next slide, please. Yeah, the next slide. All right. So what I want to do then is move on to talk a little bit about the program here in Egypt, and talk about you know, the urban challenge from our perspective, and how we have set up a community-based mental health and psychosocial support program, and how we utilize refugees assisting refugees. I hope that, Rasanta, you can have some comments along the way since she's been here and has visited our program. So it'll be nice to hear your comments as well. So the next slide, please. This is my favorite picture, even though it's old. It's from 2019. Our staff is now bigger than this, and we don't always dress like this, but it was a cultural day. And it just shows you in some ways the diversity of the staff that we have here in Egypt. The next slide, please. So, you know, why do people ask me to share MHPSS program from Egypt? I mean, why do it? You know, so my attitude always is that, you know, Cairo is one of the biggest cities in the world. It is crazy and chaotic. And basically, if we can figure out how to do what we do here, most cities in the world are not quite as challenging as this. And so if we can do it here, you can do some variation of it probably anywhere. That it's I think that our program, then it's the Psychosocial Services and Training Institute in Cairo, is a good example of a possibility of community intervention in an urban context with refugees, assisting refugees. The next slide, please. I first came to Egypt in 2007. When I first came here, I worked with the university here. And I had already worked for 20 years around the world, helping to design mental health and psychosocial programming in many different countries. When I came here, I came as a consultant, and I first designed a master's program for the university here. And while I was here, I started meeting refugees. There were only a small number of refugees here at that point. But what I was most struck by was two things. One is that refugees were not assisting refugees. Most of the people working with refugees were young foreigners who knew very little about how best to help. And so I noticed that that was there. And I noticed that in fact that the situation here was an urban area without a model. And I've been working in camps for a long time. The city of Cairo was, oh goodness, I could actually live in the city and also help refugees. So for me, it was desirable. But more importantly, I thought, well, I'll come here and I'll help to set up a model. I'll stay for a couple of years and I'll move on. I have set up a model. I haven't quite moved on. I'm still here. And I think that over the years that I have been here, that most of the time people like myself come in and come out. And I think what I've had as an advantage is to watch over time how a program can grow and develop. What we have as an underlying philosophy is that a trained team of skilled refugees can assist their own communities in accordance with their cultures and traditions. I am the only foreigner here and the only foreigner who's been here ever, and that the refugees themselves are foreigners here in Egypt. That we are a program affiliated to Terrorism. Terrorism is a Swiss international organization. We're an implementing partner of UNHCR, and we're funded by UNHCR, BP, the US Migration Group, the Embassy of the Netherlands. We've been funded by the Swiss government, the German government, and others. The next slide, please. Then our situation here is different than the situation in Greece or in some of the other countries. We have a relatively, by refugee standards, small number of refugees. We have 280,000 of them. We also have about 5 to 6 million migrants. The refugees and migrants come from about 60 different countries. For the registered refugees, about 50% are Syrian, and then the rest are from Sudan, Ethiopia, Eritrea, South Sudan, Yemen, Somalia, or Iraq. They live mostly in urban Cairo. And urban Cairo is truly, as I said before, 20 million people in a country of 110 million. It's unclear, but we have exactly how many are new because UNHCR has a very slow registration process here. But last month they registered about 4,000 new people. So every month there's more and more people that are arriving here from all the different countries. The next slide, please. Prior to coming here, the refugees here, like refugees all over the world, have had some kind of traumatic experiences. They've lost their homes, they've been victims of torture, rape, loss of loved ones. I mean, they're folks that have suffered from traumatic events. The next slide, please. Just like I said about generally, the refugees here very much have their MHPSS consequences as a result of a piece of their past, the present situation that we live in, and what are their future opportunities. Next slide, please. Egypt's not an easy place to live. No place is easy for most refugees, but this is not an easy place for someone to come. When people arrive, it's a struggle for our basic needs, social support, community belonging, basics of education, employment, just life satisfaction. It's a hard place to live. The next slide, please. An urban area, if it's no camp, there are no camps here at all. There are no instructions, there's no signs, there's no greeting committee. Most people are smuggled into the country. And so whether it's Syrians, they're smuggled in, they're Sudanese, they're smuggled in, Eritreans, Ethiopians, they're all coming into the country, usually through Sudan. The smugglers are difficult, and often people come with no documents, no money, having had very, very challenging and sometimes very dangerous experiences. When they arrive, they need food and shelter. It's an urban context. They can't go to UNHCR and say, help me, because it doesn't exist. And so they are responsible for themselves from the day that they arrive. They're searching for where to do that. And that's where community often becomes so important. If you're an Eritrean, the first thing you're doing is looking for other Eritreans, and an Ethiopian for other Ethiopians, because it's very difficult to figure out who's there and how are you going to help yourself. They want to immediately register at UNHCR, but that's not readily available. And so their greatest distress is all about how to feed themselves, how to protect themselves since they don't have proper documents to even be here. And it's often, of course, the most complicated if they don't speak the language. The next slide, please. Egypt signed the conventions allowing refugees to live here, and they say that you can come and live here, and we accept the responsibility for your safety, and we will not deport you. Unfortunately, that's not always the reality, but that is what they have signed. That they, in the signing the conventions, don't promise any kinds of social welfare. And they make very clear that refugees cannot have legal employment. There are no work visas. They can only have temporary residence visas, so they last 6 months, even if you've been here for 25 years. So it's always a temporary residence permit, and sometimes it could take 2 or 3 months to get the next residence permit. If a child is born here, they can have a birth certificate, but they can never have nationality. So children, of families that have been here for 25 years will be stateless. There's an access to public health care, but the quality of that care is not always good. Only certain nationalities can attend public education, which means most children attend community schools where the Somalis set up their own and the Sudanese set up their own, and that the children will take a Sudanese language, a Sudanese school exam rather than Egyptian. So that the system as such then is not a system where the Egyptian government is giving people any kind of permanence. What they'd like is for people to stay here a short time and leave, but that's not really the possibility. The next slide, please. The UNHCR is invited here by the government of Egypt. They have a very limited protection capacity. That their financial assistance and social welfare is only available to the most vulnerable. The UNHCR has systems for primary health care. It has systems for providing some kind of emergency care, but limited. So there is a primary health care. They're encouraging people to use the public care, but they do have some of their own. They're encouraging people to use the emergency health care within the public system, but there is a bit of its own. Mental health care is available in the public system, but you'll see that we have some of our own. Education is available in government schools, but as I said, most children go to community schools. And UNHCR provides some range of services for legal aid, educational grants, child protection, but at a very small scale. People come here hoping to get resettled. That's the bottom line. They come here hoping they'll get resettled. And frankly, less than 5% a year are resettled, which means that we have a lot of very disappointed people. A lot of people who thought it would be very different than it is when they come here. The next slide, please. The social problems in Egypt are huge. Again, it's a big country with a lot of financial problems. So especially in today's times, we've had a devaluation of the dollar, as I think many countries have been really struggling of late economically, and certainly that's the case here. The price of life has gone up and the amount of money people have has stayed the same. People really struggle to integrate. There's a fair amount of racial, religious, and national discrimination. There's sexual and verbal harassment. Egypt is known for a country where women really struggle, and there's a lot of harassment. Folks that are LGBTQI are struggling because of the laws and the harassment. So that the social problems of Egypt are very much the social problems for refugees. What's complicated is being a victim of crime. If you're a refugee woman and somebody assaults you or rapes you, you do not have the recourse to go to the police. If you have some kind of criminal case against, where something has happened and someone has robbed you or beaten you, you really don't have recourse. And UNHCR doesn't have the capacity to help you to have that as well. People are living in extreme poverty, and they are because they can't have a work permit so that they can work in domestic labor, they work in illegal factories, that they work for much less pay than others. And then there's this limited opportunities for the future. The resettlement is very limited, there's refusal of education for most, and just generally very few long-term opportunities. The next slide, please. So like I said before, you know, you can see that refugees of Egypt, like everybody else in the world who's a refugee, you know, are really struggling with the hassles of daily living. It's not the memories and traumas that are really causing them the problem. It's the hassles of their daily life and how they're going to survive and how they're going to find satisfaction of some sort. The next slide, please. Again, Egypt, like I talked about earlier, you know, people have come here and they've changed their whole lives. You know, they come here and they have to change their clothes, their style of living. Syrians come here, and like they do in Greece, they lose their economic status. We have a very strong Muslim population, and so that people of other faiths have a very hard challenge here. That there are certain values about families, about norms, about a lot of things that people have had to change to come here. Just in the style of clothing, all by itself, can be a major issue for some people. And the change to the way of life is that we have many families, and I think you have the same, where you might have a father who's an engineer, and grandpa was an engineer, and the uncles were all engineers. And now they're in a country where their children can't get higher education, or they can't even get good secondary education. So that dream of my son is going to be like me, or the son or daughter that's saying, who am I going to be? That there's a major shift in what they can expect for their own futures. That they learn quickly that they need to integrate somehow, cooperate, associate, but those feelings that are a tremendous loss for people. And that loss causes distress and a loss of hope. And it's based on the future. It's not a mental illness, it's but a of emotional distress. The next slide, please. And again, as I said, just this lack of future opportunities. You can go to trade school, but you can't get a job. You can go to secondary school, but you can't afford to go to university. Right? You would like to go home, but home is not safe. Right? You would like to go on to a third country, you're not welcome. You'd be happy to stay here if they would give you permanence, but you can't get that either. So over and over, it's this kind of sense of, I can't have what I want. So a constant dissatisfaction. The next slide, please. So it's in that context, and with all the different principles that I've been describing, that I started PSTI. The next slide. Again, it was back in 2009. And at that time, we started to train and supervise and support this multilingual, multicultural, multidisciplinary group of refugees with the idea that they provide home and community-based care for protection, psychosocial issues, mental health issues, and health issues. And that's throughout Greater Cairo and the North Coast here. Next slide, please. I base all of PSTI. Oops, the next slide. The next slide. There we go. I base PSTI on a very simple rationale. Yeah, the monkey and the fish. And to me, it's simple, but it kind of says it all. Yeah. So monkey saw fish swimming, and he didn't know that fish liked water. So he sympathized with fish and he took it out of the water thinking it would drown. And in the process, the fish died. A monkey cried and said he was only helping. That's why I started PSTI. I started it because what I saw around me all the time was that people with good intentions were trying to help. And the reality was that with a properly trained refugee staff, people could help people that with the same culture and the same context and actually speaking the same language. The next slide, please. So PSTI has grown over the years. I think we're at, actually, I think we've got a few missed here. I think we're at 220 workers speaking 32 languages. We're 87% refugees from the countries that are listed there. I'm going to explain these different teams, but you can see that we have 7 different teams that are listed here, from a community-based psychosocial team, a housing team, a health team, a community outreach team, a youth initiative, a counseling center, and a center for opportunities. That are teams that are field-based, 100% are refugees themselves. We then have an Egyptian team, it's about 13% of the staff. That the mental health team, we have 9 psychiatrists, 2 full-time and the rest part-time. We have a couple of Egyptian doctors, and then our finance and admin team are Egyptian. And then a couple of our coordinators are also Egyptian. But the majority and all of our field staff are refugee workers. The next slide, please. What issues do we deal with? Well, basically it's most anything and anybody at any time. I know that there are a lot of organizations that talk about having a scope. Their scope is, we'll do this, this, and this, and only this. We don't have that. We pride ourselves in not having a scope. I mean, basically, people can call and ask for our help for just about anything. I don't say that we have every service, we do not. But our workers are very knowledgeable about what's available. Our workers are also able to listen to people and empathize. And if there's no service, they're able to say that too. They're able to help people to problem solve and find the services wherever they can. So basically, we'll talk to anybody at any time to try to help them to try to find what they need. PSTI is a 24-hour, 7-day-a-week service. We do crisis response as well as ongoing care. Crisis response for health and mental health and situations of violence, protection, arrest, detention, GBV, child protection, basically any kind of crisis. We have teams that look at deal with problems of inaccurate information, the lack of basic needs, the need for community support, health problems, legal problems, psychosocial problems, mental health problems. So basically we'll deal with pretty much anything. Next slide, please. We have an ongoing system of intervention. So this year we have these services. We'll continue to do assessments all year long. That having a community team that's community connected means that we have a constant sense of assessment and knowing where the problems are. And as problems emerge of a different kind, then people come forward and we can start to look at being able to alter our services to be able to meet the needs of the time. So there's always the availability to change our priorities in order to be able to meet the problems that are there right now today. Yeah. The next slide, please. We use that pyramid of intervention that I talked about, so the interagency pyramid. The next slide, please. Again, as and that pyramid sets us up to have in which our team of refugees who's specially trained can do their work. It's community and home-based. It's the 24/7. We have offices, but we don't have field offices where the workers who are doing community-based work. They access people who are the most vulnerable in their homes and communities using their desk in a backpack approach. We're doing the identification of the most vulnerable by having refugee workers. I mean, a refugee worker is told by a community leader that I think that so-and-so might have a problem, and our refugee workers are trained to knock on someone's door and say, hi, I'm so-and-so from PSTI. Do you have a problem I can help you with? So we don't wait for people to come to us. Organizations that have people come to them are different than we are. It's a different clientele. A clientele that will come to you is not the same as the highly vulnerable clientele who can't figure out how to maneuver the streets of Cairo and can't figure out how to access the services. They need someone to come to them to address the issues and then help them to access the services, take them by the hand maybe, and help them to access the services. So we pride ourselves in finding the most vulnerable. Everybody has an individualized assessment. Everybody has an individualized plan. And again, that plan is culturally and contextually relevant. We do a lot in order to engage community support and are often seen as the advocates for the voice of refugees. So that's kind of the overall of who we are. And I'll talk more specifically about what we do. The next slide, please. So this is our pyramid. Okay, and then all of the lines are the interventions that we offer. That epistic psychosocial work is kind of the core. It sits in the middle, you know, and everything we do is trying to address the psychosocial needs of people. So if I have emotional distress because I'm sickly, then I might need help with my health care in order for me to have my emotional distress addressed. If I have a mental health problem, it's different than if I have a health problem. But frankly, psychosocial care and support is necessary for both. Right? And that what we try to do then is set up a range of interventions that helps to reduce emotional distress through these interventions. Yeah? All right, you'll see I'll go through the whole range of them. You'll see that I think we're different than many organizations, is that we have a very strong level 1. Many MHPSS organizations would say, we don't really do level 1, and that maybe we train school people in order to work with children so that they can be compassionate. Well, that's one way of doing MHPSS at level 1. Because of the lack of services here in Egypt, and the lack of reliable services and the lack of the integration that's possible with government, then we end up doing far more at layer 1 in order to reduce people's emotional distress through providing some kind of service. And our layers have teams that are interconnected. So our psychosocial team, our health team, our housing team, everybody works very closely together with one leading and directing the other and supporting the other. The next slide, please. We assist about 2,500 cases or about 5,000 people a month. Next slide. Now, as I was beginning to say, is that, that much emotional distress is due to the hassles of daily life. So that's where we begin with layer 1. Next slide, please. At layer 1, we have helplines. So we have these 24-hour helplines that they're not just a phone answering service. They're a phone answering service leading to a referral service, leading to someone going out if someone needs to go out. So sometimes people just call and say, where's the UNHCR office? Or, I need help with this and this, or I need to know this and this information. Well, those are easy. I mean, it's easy to give advice. Is that we and our workers are very well trained to do that. We can make referrals. But most importantly is in the middle of the night when someone calls and says they've had a road traffic accident, we can activate people to help. Or they say, my son is getting ready, he's outside with a rope and we think he's going to hang himself. We can get there in order to help. So it's not just a talking line, it's very much an action line. At level 1, that we do a lot of advocacy for people for basic needs. Some of the systems are not well set up and they can't do other partners are not able to do like a proper assessment of who's most in need. So because our workers are refugees and they go to people's homes, then they're able to come back and say, I saw their home, I saw their situation, and they are therefore eligible or should be eligible for this, 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 and this. No refugee, no worker at PSTI should ever be in a situation where they go into someone's home and the people are hungry and they can't do anything. So that we have a food voucher system. So that we're sure that nobody ever has to be put in that situation where they're walking away from a hungry person. That we make sure to take care of people immediately, and then we work on the more long-term plan. Frankly, that at level 1, we are dealing, even though, it's level 1, but it's life and death. That the services that we require, that we do are life-saving. It's very time consuming. The services at Layer 1 need a lot of community cooperation. There's no way in the world that we can do these things without community cooperation. And as I said, we go to them and we help people to access the most vulnerable access services. The next slide, please. We have an information sharing team. In addition to the helplines, we have a team speaking many different languages that are going out and providing information. We're right now doing a big suicide awareness campaign. We've had unfortunate, too many suicides. So we're doing a big campaign with informing people and raising awareness around suicide. We do a safe living campaign, teaching people how to cross the street in Cairo, teaching people how to find a proper school, how to find a safe job, how to access safe housing. We advise people about school. We have a new program that's called the Neighborhood Harmony Program, where we're trying to help new arrivals to meet their neighbors, introducing people and building relationships between people right from the very beginning. So you arrive, you're moving into this new apartment. We have a small team that will help people go and knock on the door next door and say, hi, I'm your new neighbor, and help them to introduce to each other, get to know each other, and then building activities for the communities. So with refugees and Egyptians together. The next slide, please. We have a housing advocacy program where in this situation that safe housing is critical. Sadly, because of the economic problems, we're finding that there are more and more people who are facing eviction or are homeless. People live in very poor neighborhoods. COVID at the very beginning caused a lot of loss of jobs, but even today, there's still less jobs available. What we find is that we can help people to access affordable apartments. We can help people to financially plan, find roommates, sometimes conflict mediate with landlords. But sometimes our program is most useful for housing protection. Basically, in a big city, UNHCR offers no protection. The police offer no protection. If I am assaulted on the street and the person who assaulted me knows where I live, or that for some reason my house is a place people know and it's a danger for me, the only choice that I have is to move to another neighborhood. There is no other protection here. And what we're able to do is help someone to do that. They can't do that on their own because they're not able to pay the security deposits and new rents. They don't have that kind of money. So we're able to help someone move from one neighborhood to another neighborhood in order to have protection. And then follow that with a team, with people that are going to offer them support to make sure that the problems don't follow them and that they don't have problems in the new neighborhood. Yeah. Do we have any questions as I go through the services? Anybody have any questions so far, or I'll just keep going through and we'll take a break in about 5 minutes. Maybe I'll just finish level 1 first, yeah? Right. So that the next is we have a health advocacy service that I'm sure that probably in Greece it's the same, but if you're a refugee, you can't work as a nurse, for example, here. You can't because you don't have the same certificates and whatever, and they don't allow it. So, but we have refugee doctors and nurses who are well qualified, and we use them as health advocates. So we have a 24/7 emergency advocacy program. So in the middle of the night, if somebody needs healthcare, they can call us. They can say, I had a road traffic accident. They can say, I have pain that is excruciating and I need help. I'm bleeding, I was assaulted. And they can call our emergency lines, and a refugee doctor or nurse will meet them at the hospital. What that does is it means that as we are, understanding in the urban context, not every doctor or nurse sitting in that hospital recognizes they're supposed to help a refugee. Many of the refugees don't speak Arabic. So what we do is we have people who just meet them. They meet them there. We know the services. We help them to maneuver their way through the service. We help to mobilize community support for that sick person. So it's not just us doing it, but we mobilize community leadership or family members to help. And then we advocate for them to get the health care that they need. We make sure to accompany them, support them during hospitalization, and to do that kind of thing. We partner with the UNHCR Partners for Health, who are also responsible for that. Additionally, we have a nursing series of nurses who provide home-based healthcare. Here in Egypt, that there is no public service for that, but we have people who are, permanently paralyzed, people who are bedbound, people who have an accident and need care and don't have proper family support. So we have nurses that go to people's homes and help them to get that care, or to teach family and community how to take care of them. Yeah. The next slide. This morning I was at the Center for Opportunities. We were doing an orientation for embassies. We're trying to raise some money. That, as I mentioned, in the urban area, that everybody needs to be self-sufficient. And if you're somebody with some kind of physical or mental challenge, it's particularly difficult. People would like to believe that UNHCR will give you support. But that's just not the truth. And so if that's not available, then people have to find ways that they're going to support themselves. So we've set up this small life and income generation project. People are able, in wheelchairs and braces and crutches, people who are chronically mentally ill, families who have children who have mental health or mental challenges of some sort, are all the clientele that come to get training there. They come for about 7 weeks. They have life skills training, income generation training. And after 7 weeks, we help them to get started in something. Most of them do something from home. They're not folks that could easily manage this big city. So we teach them things that are easily learned and then can be home business. Some connect to their communities. We do a lot with connecting them to the communities, and the communities then will sell their products or to help them. But most importantly, we're trying to help people to be self-reliant. They learn phone repair, electronics repair, henna, hairdressing, makeup, cooking, baking. We are teaching people how to set up babysitting services, how to make perfume, crochet in the arts, different things like that. And in a period of 7 weeks, they learn, and then with the help of a case manager, are able to mobilize the skills that they've learned. Yeah. That's a whole series of what we do at Layer 1. It's a lot of services at Layer 1, which is quite different, I think, than some other programs do. We see all these services as essential to build the capacity of people to manage the emotional distress and problems that they have here. Now, I saw that there were questions as I was talking. I can't always see the questions at the same time because I'm on my phone. I don't know that I'm going to see them at all. 1 second, let me just see if I can open the questions.
What is the formal state of Egypt handles concerning MHPSS support of refugees is one? The formal state of Egypt handles.
The former state or the formal state? You're asking
formal,
what does
formal?
There isn't any. So you have a lot of countries. I've worked in other countries. I remember in Uganda, one of our goals was to get the government to have a policy on refugee care and on MHPSS with refugees. There's no interest in that here. UNHCR has a difficult time getting them to do the more traditional protection tasks. That at the same time, for next week, actually, as an example, I run an MHPSS working group. The government's part of that. IOM and UNHCR, we have exchanges with the government. So we sit with the Mental Health Secretariat and we talk about how we do collaboration. I do training. I do training with the government. I help to supervise their trauma clinics. I help them to start their helplines. So refugees are able to access some of that. The problem is every service here is very overwhelmed. So if you have a service already overwhelmed by Egyptians, then they politely, to be nice to me and us, will take, you know, one refugee in the trauma clinic, but they're overwhelmed. They don't have the space for it. They attend the working groups, but there isn't a policy. We're nowhere near that. It's not that level of interest. There's signatures, you know, for certain things, but it's not the same thing as a policy. Does that answer that question? Yeah, Vivi says thank you. All right. All right. Other questions that are there?
Then there is another one. How does training work for your team that is so diverse? I'm thinking of language and other cultural differences that may be relevant for training.
Yes, I'm going to, after I finish the layers of intervention, I'm going to tell you about the team and I will talk about what training we do. So I will talk about that. Yep.
Okay.
Another question?
How people receive or accept your offer? I mean, are there people who deny your offer for services?
Certainly.
And how do you react to this?
Certainly. I mean, you know, that, you know, knock, knock, knock on someone's door. Your community leader suggested that you might have some kind of issue going on, and I work for PSTI, can I be of help? The person says, I have no problem. PSTI workers from the community, they speak their language. Usually they'd be invited in for a cup of tea. So they sit, they might make small talk, they chat, they try to build some kind of trust. The person says, I'm not interested. They're able to say, well, here's my telephone number. At some point, if you need me, call me. Now, if it was, however, that the community leader told us that, in fact, it's a family and the woman is being abused, then we would take a stronger approach. Again, the team is a community team. They'd go with the community leader. They'd go together. Knock, knock on the door. Community leader can be more direct. Community leader says, I understand this and this is a problem here. I've brought help for you. All right. So that there are times when, especially with protection issues and safety, we're going to be more direct. With mental health problems, you know, we make sure that there's family and community working with us with every mental health situation. Yet, you could have family and community that are the problem. You know, that knock, 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 somebody's going to commit suicide. We go in to help, community is with us. Community takes one look at the situation and walks back out the door, or they don't want to be involved, or they don't want this, or they don't want that. So we put a lot of effort into training communities so we don't end up in that situation, put a lot of effort into building rapport with communities, helping them to accept responsibility in advance. So there's a lot of pre-work done so that when you walk into an emergency situation, usually we have a partner. The next question should be about privacy and confidentiality and all that goes with it. Well, you know, community leadership, they know a lot. So if they bring us, there's not that issue. If we need to bring them, all right, then we would do that when there's a risk to life, you know, and if there's a risk to life, someone calls us because someone's waving a knife and just tried to kill someone, then the confidentialities are different. But in a mental health emergency, our workers go in, they might be dealing with a patient that is a person that is very much not wanting our care, but they're psychotic, they're dangerous, and we will ensure that they get the care that they need so that we take a strong stand. Yeah. And because if we don't, they're going to either end up hurting someone or end up in a lot worse situation with police or this or that. Better off having us manage them and help them get into the mental health system as a means of protection. I hope that answers your question. Yeah.
Yeah, thank you very much. And there is Fotini who has raised hand, and then Dipari who has sent from the chat two long comments.
Say again?
Can I ask?
Yes, Fotini.
Yes, my question is how long the program is running in order to establish the engagement of the community?
We've been around since 2009.
2009, and when you saw the engagement of the, because it is 2009, it's until 2022, it's many years.
Yes.
So we know that the community needs a lot of time, and one of the challenges of humanitarian is the short programs.
Yeah.
That is not allowed so much engagement and development.
Yes.
Especially not emergency situations that have to follow development, and especially in European context, because it's different the context of different countries. So how long you saw that this became more stable and the community has the ownership of that?
Yeah, it's a good question. You know that I've worked in many places where the goal was to build the government and civil society capacity so that they took over programming. I mean, that's always the goal, that people can help themselves. Unfortunately, here in Egypt, that is just, the government doesn't have that interest, and it's not going to happen. And, we work at it. It's not like we don't work at it, but it's not going to take it over. That we also have the issue that the kinds of problems that people have, the communities have been trained, the communities' capacities are built, the communities are able to deal with a lot more today than they were in 2009. That's absolutely true. But, when you have a rising suicide problem and a substance abuse problem and a this problem and a that problem, the sadness is that the problems are rising and the communities need more professional support in order to help. And that what we've chosen to do is have that professional help be psychosocial workers trained in order to be able to do the next level of care with their own communities. We have not had problem maintaining our funding because people can see that what we do is useful and necessary, and we have to prove that. But we just finished one 5-year grant, and we'll get another one soon, and just finished a 3-year grant, and we'll have another one soon. So I think that some of that comes from the circumstance. Yeah, so the circumstance here is in many ways not a usual circumstance. I can now see the questions.
Can I suggest something? Can we do the 5 minutes?
Sure, I'm
break?
sorry. Yes, good idea. Yes.
Yes, and with my pleasure, Nancy, to share my experience during my training.
Yes, I'd love that.
On.
Yes, that would be terrific. All right. Okay, so let's take a 5-minute break, stretch, and then I'm going to continue with some of what you've asked, and we'll have Prasanthi speak to us. Thank you. Okay, I'll answer the couple of questions and then I'll move on. Someone has asked about training. I think that Parvati has asked about training. I think one of the places to start, as I said before, is about do the PFA training, the psychological first aid. That will already help you with some communication skills. I don't think you have to have an entire degree in order to have the kinds of communication skills that you're describing. I think there are ways of getting it through courses and not just, I don't think you have to have a whole degree in order to do that. Deepali asked, it seems that refugees have many different needs. How to support prioritize situations, whether if they're approached by your team. People have many different needs, and in the end, some we can help with and some we have to help them to accept their life situation. We spend a lot of time helping people to accept their life situation. It's a very sad and kind of depressing thing to have to do. And yet that's reality. We now run support groups, special support groups, 3-session support groups that are designed to help people to build personal strength, personal capacity, personal responsibility, and to accept the situation that they're in, or at least to be able to live with the situation they're in. Plans to put place for children, you asked. I mean, we are very much a family-oriented program. We're not a women's and children's program, we're a family program. Maybe that's my background as a family therapist, but it's more so that it's the cultures that we work in here. These are family cultures. And so we very much work with children, but work with children in the context of their families. I'll explain now with layers 2. I'll do quickly just to explain some. And we have some child and youth oriented interventions there. And Miriam asks, Miriam, I think your question is an interesting one. Someone's saying they can't hear anything. Are we hearing me?
Yes.
Yes,
Yeah,
okay.
just fine.
So I think it was just, you can hear now. Okay, good. All right. The question about the workers and society, I'll take it to a little bit different. The workers who come to work for PSTIC, as I'll describe, many of them were community workers. They are not university educated workers. They're trained by us, as I'll explain. Their status in their community changes by the nature of the job that they have here. They're very much respected by their communities because of the training and the job that they have here and the service that they provide. And that's a very important, very important part. How that changes them with the Egyptian society, well, it changes their attitude. I mean, they feel like a useful, helping person. And so that makes it easier for them to live here and to adjust. I think anybody who feels that they have a life purpose has an easier time living anywhere. So I think that for our workers, certainly that's true. I hope as well as for our clients. Krisanti, let me just talk a little bit about the other levels of intervention, and then I'll ask you to talk about your experience here. Is that okay?
Great.
Okay.
Let's share screen.
All right. So let's just move to the next slide. It says layer 2, family and community support. Yeah, do we have the slides? There we go. Keep going. Keep going. One more. That's it. All right. So at this family and community layer, nope, back one. At the family and community layer, we have a lot of different interventions. That the interventions, these are interventions that support family and community. As I mentioned, I believe that PSTIC is very much of the people. Krisanti, just go back one slide. At that layer, at layer 2, we do, as I mentioned earlier, lots of community awareness raising. We have teams that do that. We have teams working in community mobilization, making sure that communities are working alongside of our workers to deal with the difficult situations. And as was asked earlier, building their capacity so that they can deal with many situations and don't need us for everything. I mean, that's, of course, incredibly important. That we're working in family and community conflict mediation and problem solving. We have a program for children with special needs that is a family program. Basically, kids here have a hard time getting suitable education. We very much advocate kids with special needs are in school, and that families are helping to make sure that they're in schools that are good for them. But we run a recreational program, a socialization program, where families with their kids are coming and playing, whether it's play and the parents and getting to know each other and socialize, and the kids making friends and the parents making friends, and then doing parenting work alongside of it. And then the other is that we sadly have a serious problem with Sudanese and South Sudanese gangs here, where they target the refugees, and there's a fair amount of assault and robbery and a lot of very serious gang violence, sometimes against each other and sometimes against the community. So we started a program now 3 years ago where we hired and trained ex-gang leaders to become mentors working with youth. It's an all-male team working with the boys in the gangs. We hope to start the girl program actually in the next couple of weeks. And what these workers are doing is working in school. They have a life skills program we designed for schools, helping kids to deal with bullying and violence and saying no to gangs and relationships between them and girlfriends and mothers and communities. We are doing community action with these kids and then conflict mediation. The youth team goes out in the middle of the night if there's gang violence and helps to stop the violence and helps to resolve the conflicts. Our health team is there to respond for any kid that gets injured, be they the perpetrator or the victim. And then with the help of the youth team, try to help the child or the young person, they're not usually children, they're young adults, who have been somehow assaulted during gang violence, and then try to help them to create new life, opportunity, things like that. The next slide, please. At layer 3, our psychosocial workers are trained to do psychosocial support as well as to do counseling. Some of them are very fine counselors and they work within people's homes doing counseling. Others of them do primarily psychosocial. But we now have a counseling center. We made a decision a few years ago that our field work served one population, our mental health work served another, and that we decided that a counseling center really was a missing link. So we set up this counseling center. We trained refugees as counselors using PM+. It's been a very interesting, of course, COVID was right in the middle of it. So we did a lot of work online. I published a couple of articles during that time, one specifically about PM+ online. But we do a lot of individual, family, and group work within that counseling center with our refugee team. And the next slide is that we also have a whole service for specialized care. That even though there's only a small percentage at that layer 4, it sure is important. All right, and it's really very sad and difficult for people at that layer 4 to kind of disappear into the crowd and to find themselves sadly at risk and without the adequate care. So we do a lot of community awareness raising so that people are better aware of issues and deal with stigma and try to improve relationships. The next slide, please. And we have our psychosocial teams are about 10 people a team, and each team is assigned a different psychiatrist. So we have 7 teams, each has a psychiatrist. And the psychiatrist is there to help them with emergency as well as ongoing response for people who have mental health problems. So in the middle of the night, if someone's out there with a suicide risk, it's the worker with a partner, there's always 2. A psychiatrist is on the telephone, a team leader is on the telephone, tremendous amount of support in order to make a decision about whether we're doing outpatient support or whether or not we're helping someone to be hospitalized. We run our own adolescent and child clinic and family clinic with that. We run an EMDR clinic. We have, as I mentioned earlier, support sessions, and that we also, you asked about the government. This is not an easy country to work alongside government, but as I mentioned earlier, we put a lot of effort into, I offer training and support to government workers and have been very much working with them to improve government services. The more they improve those services, the more that we're engaged with it. So there's a lot of effort placed into that as well. And the next slide. You asked about, the team, and In order to have a team of refugees to assist refugees, and this is primarily for our psychosocial workers, that the selection process is really important. We put a tremendous amount of time into the advertising, the promotion, the discussion with the community, and then the selection process. We are just concluding a 5-week training with 21 new psychosocial workers. I mean, they were selected through a process of many interviews, you know, 3 interviews a person with people from refugee psychosocial workers from their own communities, as well as others. And we look for personality and commitment, and not for what schooling did they have before. That we have hired, I think in all the time that we've done this, a handful that had prior training or education as a social worker or something like that. Most of the refugees who come here don't have that kind of background. They wouldn't, their countries don't have that kind of background. So when we're selecting, we look at personality. We have kind of a profile of an outgoing, compassionate, committed, highly mobile, flexible, available. I mean, those workers we've been working together for years, they do the interviews, I do like a final interview. It's rare for me to kind of say, no, that's the wrong person, because we've learned a certain kind of prototype that works best for us and that works here. That we can train skills, but we can't train a personality. I can't train the outgoing personality that's able to knock on someone's door and say, hello, I'm Pistic, or the person who's willing to not give up when a person has resisted them, and yet you can see that they have a major protection or mental health problem. So it's a very selected group of people. The next slide, please. And we train them and train them and train them. That they begin with this 5 weeks of 6 days a week, 8 hours a day of classroom training, mixed with some field training, mixed with team meetings. They're learning. They need to learn certain knowledge, you know, basic psychosocial awareness. They need to know what mental illness is, mental disorders are. They need to understand child protection, GBV, human rights, a lot of knowledge they need. Then skills. They need good communication skills, basic counseling skills, problem solving skills, conflict mediation skills, psychosocial support skills, case management. They need to understand how to do a mental health assessment. They need to understand how to manage high risk and emergencies, and they need to know about referrals and advocacy. And they need to learn work skills. Many people come to work for us who've never had a job before. Even though they're not a young group, our teams we prefer older workers. Our workers are, you know, usually 30s, 40s. I have workers who are 60. We don't hire less than 25, and even that I hesitate, because we want people to be taken seriously by their communities, and sadly, young people are not taken as seriously as folks with more life experience. So that's important to us. That we make sure that we work on attitudes, ethics, being non-judgmental, making sure that our workers can work with everybody. There is not, you know, it's not like there's nobody that we won't work with, so that they have to be able to have open minds. Our training is classroom, it's knowledge, it's skill development, it's practice. And practice and practice and practice. We practice cases, we practice, you know, we practice case after case, role play and practice. And from the very beginning, a very open environment where workers, as they're learning, are able to talk about, you know, what's hard and what more they need, and lots of support. After a worker is trained, they join a team, and they will continue to have training there'll be a training every week. There'll be refresher trainings for a few days regularly going on. I mean, there's a constant flow, as well as they have buddies, yeah? And once they finish this training, you know, every single one of them will have a buddy. and they will be accompanied by the buddy. The buddy they'll be able to call at any time, day or night, asking questions. So not only do they have a team leader, a deputy team leader, and a psychiatrist, they also have a buddy. The next slide, please. Because psychosocial workers and the job they have here, when you have 24 hours, 7-day week work, you need lots of support. All right, so we have weekly team meetings, we have daily phone calls, they have individual supervision, you know, with their team leader twice a month, with their mental health advisor once a month. They have group supervision every week, group support sessions once a month. We have WhatsApp groups for fun, for information, for support. We have lots of playful activities. You know, Nile boat next week, a football league the week before, a henna party the week before that. Lots of supportive activities in order for people to be taken care of in the process of having a very hard job. The next slide, please. And that's their challenges. Their challenges, it's a hard job. They have to be able to manage stress. They have to be able to maintain the morale and feel appreciation of the work that they do. We need to work at maintaining core ethics, managing the complications of working with communities, a job that has constant emergency interruptions. You have a schedule and then you have an emergency. So there's a constant interruption. And every day there's a new challenge because you're expected to be able to work with whatever comes your way. So there's an increasingly need for new professional capacity. The next slide, please. To do this, I mean, our teams are paid. That they have been acknowledged recently by UNHCR as a paid professional team of refugee workers. I mean, that is what's fair. I mean, they are, you know, they are doing a professional job. And that's very hard here because we, as I said, they can't have a work visa. So they can be a paid volunteer. To meet their challenges, as I mentioned, they're in small teams, they have the psychiatrist, they have lots of training. They're never alone. I mean, an emergency is very hard. They are never alone. They always have somebody that they can count on. We have loan systems. We have individual counseling with people if they desire it. So that there's always things that we're doing to try to make sure that the workers feel that they're taken care of. And the next slide. You know, the context of Egypt has a lot of challenges, and the job that we choose to do within that context has life and death risks that never stop. So we have to be continually aware of what's happening so that we're up to date with how to have interventions that are most useful. There's a never-ending stream of people arriving, so we have to be ready for that. Every day, you know, UNHCR and other partners more recently have less resources and we have more refugees. So we have to continually be ready for that and how to manage it. I think a lot of what we're able to manage here comes from having a very direct and straight communication style. It's a place where people can talk to each other and share what their issues are, their problems are, their successes are. So hopefully it's that kind of environment. The next slide. Oh, let's skip that one. And now the next slide. The next slide. Nope, one before it. Let's look at the sunflowers and Chrysanthi. Your turn.
Thanks a lot. I just want to say about my experience in the training that Nancy Pistic organized in Cairo once a year before COVID. It was a totally experiential training. I spent the majority of the 10 days there in the slums of Cairo, in the homes of Pistic POCs. And I had the opportunity to learn from them how they feel when a member of their community provides these services. I remember that I paid a visit in a beneficiary who were SGBV survivor. and she started telling her story, and how important for her was the fact that the whole community, even the leaders, in collaboration with the PSTIC professionals, supported her change home immediately and protect her from the perpetrator. And also I realized that the disclosure period for the POCs was less than if you provide this, if the service is provided by a professional, because they have the same background, they have the lived experience, the community social workers, and they feel more comfortable to receive support from PSTIC. Also, I mentioned by myself that the refugees there, they're separated to Syrians and non-Syrians. I realized that when I visit the Syrian neighborhood, that it was completely different from the rest of them. It's looks like that as an Egyptian area, and they were well developed instead of the other areas in Cairo. Also, they follow the holistic approach and a lot of outreach activities. This is something also mentioned, Nancy, that we are not expecting they didn't expect the POCs to came to PSTIC and knock the door, but they perform home visit and they try to strengthen the existing facilities of the community. In some cases, there were inside the slum community centers who runs by the community themselves. This is the way that the community social workers and PSTIC work inside. I also feel very proud that I met my colleagues of the staff of PSTIC, who were amazing. I remember that during the field visit, always their phones ring because an emergency came up, but they were very polite. They tried to manage all of the cases and try also to explain to us how PSTIC work on a daily basis. This is my feedback so far. I think that you have to, I don't know when is the next one round of the training, but it's a unique experience and you have to attend it for me.
Thank you. I was teaching last week in Italy and with IOM, and I said that I committed myself. So if we take the slides and we move down a few, you'll see that we'll get to the slide. I think we can skip the others. Yeah. Oops. Yeah. Skip that one. Keep going. Keep going. That one. Whoops, one back. So the plan, I think September might be a bit optimistic, but I'd like to have a training by October. I think that COVID is, I don't know, COVID is COVID, but it's controlled enough that I think I feel that it's safe enough to bring a group here. And so we will have a training. It's usually 10 days. They're usually two. The first is a 10-day training that is about mental health care in the urban context. So people spend time in the classroom and people spend time in the field. We run it with Urban Life, who is our partner. And then I also do a training of trainers about urban mental health and psychosocial intervention. But I'm thinking September or October, so we'll send you the details of that. I saw one more question. Thank you, County, so much. Let me just see that I see thank yous, but I saw one more question. Does anybody else have questions? Your question, I guess it was Miriam. She had asked about staff support, which I think I've explained. The challenges for our workers, and are they different than the Egyptian challenges? Absolutely, yes. I mean, so first of all, our Egyptian workers are not field workers. Our Egyptian workers are all our office workers, with the exception of the psychiatrists. So their jobs are just very different. Our refugee workers, I mean, are all field workers, and they're all 24/7, which the others aren't. So their experiences are quite different. You said about the staff support. I think that I mentioned about that. I think being a psychosocial worker at PSTIC, or just working at PSTIC for a refugee, has their lives changed. I mean, that's what they say. That, for the most part, they were living here, some of them as domestic workers, cleaning someone's house, and they end up here. And so that their life has had the opportunity to find direction, and to feel life purpose. Yeah, and I think that's very, very important for everybody and for them. Yeah. Other questions or comments?
Can I ask a quick question?
Sure, of course.
Yeah, this is Parvati back again. So thank you for that wonderful presentation. And so I guess some of the takeaways from the intervention that I feel that we could employ in a migrant laborer setting in urban India, who have actually come from a rural context. So they are not, according to the definition of internally displaced, but they are still displaced from their families and have come to the urban setting to work. So I'm hoping some of the takeaways from your intervention may be applicable when we try to develop a mental health, an MHPSS intervention for such urban migrant laborers.
I think that, what I would hope is the greatest takeaway for everybody. There's a few things. One is that I would hope for those who didn't know, the understanding that MHPSS is a range of needs and interventions, and it's not just a one thing, and that there are lots of people, they have different needs, and we need to make sure to do the right interventions for the right people. And there's very much the need for these basic interventions to improve emotional well-being, as well as family and community, and not just counseling and drugs and medication and psychiatry. So I think that's the one thing I'd want to be sure that people got. I think the second is that the urban context is very different than the rural or the usual camp kind of situation, and that we need to reassess people to be sure that we're doing interventions that are best for them for the urban context, and not just kind of try to take our camp interventions and place them into the urban area. So we need to reassess and redesign. And then the last thing is about refugee workers. I just can't imagine trying to work without them. They know how to work with their families and the communities of who are the people in need. And my job is to make sure that they are trained, that I facilitate them, make sure that they have what they need to do their work, give them an open environment in which they can learn and support each other. And but my job is not a client job. I love working with clients. I'm a psychologist. That's what I would love to do, but that's not where I belong in international work. So, today I'm raising money, I'm designing programming with them, because I have some skills that they don't have, but it's all with them and with their lead, and me listening and following their lead. They're the best workers. And I think that I hope that, you know, we can understand that refugees, assisting refugees is an essential part of the work that any of us do, no matter what location we're in. And so I hope that we take that away today too.
Yeah, so I was thinking, what is migrant laborers helping migrant laborers in an urban context?
Yes.
Because they're not typical refugees, but they're still displaced in some way,
Yes.
but by choice and circumstances.
Yes.
Great.
Yes.
Thank you,
Yes.
Dr. Barron.
Sure. Other comments? I hope that this is what you came for today. I hope that it's been useful, that when I get to a different internet that allows me to, I will send the PowerPoint. Oh, yeah, I guess you have it now. No, I take it back. So that you can send the PowerPoint something to everybody. It's for me, I'm more than happy for you to send it.
Yeah, okay. So or else we have recorded it and we are still recording it, and we will upload it to our channel on YouTube, and anyone can have access to this webinar, for which we thank you very much, Nancy. It's I don't know how many times I have heard about your work by you, and I'm always impressed by all these things that you do, but not because of the quantity, but of how can I say, the concern about people, about dignity of people that is behind all these things. And this is very inspiring, I think, for all of us, and it's something that is motivating us to think that we can do similar things, not identical, but we can be inspired by this. Thinking that people are complex, let's say, entities, and we need to have in mind this their complexity, and also their need to be treated as humans, as subjects, not as objects and receivers of services. Thank you very much for this.
Yeah, thank you very much. I hope to see you in Greece, or have you come and visit us here.
Wish so.
Thanks a lot, Nancy.
Thank you.
For your availability.
Thank you. Thanks for inviting me.
Okay, bye.
Bye-bye.
Bye.